Good afternoon, everyone, and welcome to the second annual Within Summit. My name is Ashley Barkoviak, and I'm the Clinical Operations Coordinator here at Within Health. Today, Brittany Ashmore, I'd like to introduce you to her. She is a licensed marriage and family therapist who specializes in treating eating disorders with experience in outpatient, IOP, and PHP levels of care for eating disorder treatment. Brittany additionally is passionate about providing neurodiversity affirming care and values understanding and working with the intersection of autism and eating disorders. Brittany has experience presenting workshops on providing eating disorder treatment in the public mental health system of care. Brittany is also a primary therapist here at Within Health, and we are so grateful to have her here with us. Today, Brittany will be presenting on the topic of deconstructing provider biases in eating disorder care for autistic individuals. Before we get things kicked off, I'd like to do some general housekeeping in regards to the CEU credits. Evaluations will be sent to your email that you use registering for this presentation. Once the evaluation is complete, you will receive a link to download your CE certificate. Please utilize your CEGO dashboard for all things CE related. The video recording for this presentation will also be available on your CEGO dashboard. However, you will not get credit for watching the video. You must attend live in order to receive your credit. And again, in order to access that video, please utilize your CEGO dashboards for all things CE related. If any technological issues do come about and you need to change devices during the presentation, you will receive credit for this. For any additional questions, concerns regarding obtaining the CE credit, please feel free to email me, which I will provide in the chat below. I will also provide Jamie Singletary's email in case anything does arise as well, and the general contact info for CEGO in case any technological issues do arise and you have issues getting that CE credit. Now that we've gotten all that, I would love to pass things over to Brittany and listen to her presentation.
Thank you. I'm so excited to be able to be here and give this presentation, and I'm really hopeful that it gives us all just plants some seeds for beginning this process of really starting to deconstruct and question and better understand our biases when it comes to providing care for our autistic clients in eating disorder care. So we're going to start out with just kind of some foundations, some basics when it comes to the neurodiversity paradigm, a little bit of neurodiversity 101. So when it comes to shifting away from the pathology paradigm and really starting to look at and understand the neurodiversity paradigm, I think in the eating disorder field, we really have a framework here that some of us are probably familiar with, which is the Hayes framework, which really was this like paradigm shift around health and body size and what that means. And when it comes to the neurodiversity paradigm, I think it is in ways a similar paradigm shift where it really calls us to take a step back and ask ourselves some really important questions about the systems that we exist in and the society that we exist in and the beliefs that we hold. So some of the questions that shifting away from the pathology paradigm requires us to ask is, who determines what is considered to be disordered? How have the historical, social, and political landscape determined what is normal and healthy? And those have quotes around them. And how has neuronormativity influenced the values and judgments that we hold towards differences that other people have? So I wanted to also cover just kind of some important concepts and terms within this paradigm. So neurodiversity describes the idea and the concept that like other human traits, like other biological traits in biological systems and populations of animals and plants and things like that. There's diversity. And so in neurodiversity, it's the concept that just like other traits, neurotypes, or the way that our brain is wired and operates, are diverse in the human population. Neurodiverse is a term that describes an entire group of people. So you wouldn't use neurodiverse to describe one person. It describes a group of people, and it describes the fact that that group of people have many different types of neurotypes within the group. Neurodivergent describes a person whose neurotype does not fit within the majority, kind of like the what is deemed normal in a neuronormative society. But in a neurodiversity affirming paradigm, it's just kind of the acknowledgement that neurodivergent means that that person's neurotype doesn't align with the majority when you're kind of looking at overall neurotypes. Neuronormativity describes the belief system that places value on neurotypicality and pathologizes those who differ from neurotypical brains. So this pathologizes anything that kind of veers away from neurotypical ways of being, ways of acting, thought processes, ways of communicating, learning styles, etc. And neurotypical describes a person whose neurotype fits within the majority. And again, under neuronormativity, these are kind of the neurotypes that are going to be deemed as normal. In the neurodiversity paradigm, lived experience is something that's really important and a big part of this paradigm shift. The neurodiversity movement in general is a grassroots movement that values lived experiences, that views people as the experts on their experiences. And it doesn't have like one leader. And I think it's also important to point out that it encompasses all diverse brain types. And so when we're talking about neurodiversity in general, or someone who is neurodivergent, it doesn't necessarily mean that we're talking specifically about autism. It can be any neurodivergence, from autism to ADHD to bipolar to PTSD. So it's pretty much any way that someone experiences differences in their brain type. When we hone in and look specifically at autism through a neurodiversity affirming lens, again, this is still driven by lived and subjective experiences of autistic individuals. It uses identity first language. So meaning rather than saying somebody has autism or a person with autism, you are using autistic to describe that person, which really is informed by an overwhelming majority of autistic adults identifying that being autistic is a part of their identity. It questions and dismantles some of the stereotypes and stigma that have been associated with autism, which we will get into in much more detail. And it views and believes that autism is a neurological difference. It's a natural variation, that autistic brains are valuable, autistic people are valuable, and that it's a part of human diversity. And the gold infinity symbol that is kind of on this page is the symbol for autism from a neurodiversity affirming lens. And the reason it's gold is because gold's periodic element letters are AU. So I think it's pretty clever. So moving into kind of the experiences that autistic people have in healthcare, to kind of set the stage for what it's like to be autistic and to be seeking healthcare, eating disorder care. I think it's really important to highlight that autistic people are dying at much younger ages than their non-autistic peers. The life expectancy for an autistic person is 36 to 54 years old. I want to say the median in that is 39.9, something like that. And so it's significantly younger than non-autistic life expectancy. And we will kind of get into some of that. But the leading causes of death for autistic adults is heart disease and suicide. And when I was making my slides for the presentation, I had a different picture on this slide. It was kind of just a stock photo, but I changed it last night as I was preparing. And the picture on this slide is now the Spirit of St. Louis, the first airplane to make a trek across the Atlantic Ocean. And what does that have to do with autistic people dying? Probably not a whole lot to you until I share a little story with you all. So the reason why I put this picture on the slide is because as I have spent the last couple of years of my life really doing a deep dive into understanding autism from a perspective of really understanding the subjective and lived experiences and the depth and breadth of what autism is, I connected some dots that were missing in my family, and realized that my uncle was most definitely an autistic person who never received a diagnosis of autism in his lifetime. And he died at age 61. And he did live 7 years longer than the high end of this life expectancy for autistic people. But also 61 is still significantly younger than what one might expect for someone's life expectancy in the United States. And so as I started to learn more about autism and started to think about my uncle in this way, and as we go through some of these access to healthcare slides, some of the challenges are going to be highlighted, but it really hit home for me that people not having knowledge of their neurotype and not having access to diagnosis and not having access to accommodations is a real thing. And my uncle, the reason, so to tie it back to the Spirit of St. Louis, my uncle spent his life devoted to becoming an expert on the Spirit of St. Louis. And he was an expert in this area. He actually built multiple replicas of the Spirit of St. Louis. He spoke at the Smithsonian about the Spirit of St. Louis, and really spent his life involved and engaged with something that was so meaningful and so important to him. And in that, he also didn't have a typical job or access to healthcare, or access to insurance. And there were many things that I think contributed to his early death. And so I wanted to share that just to kind of humanize these numbers and give a little bit of context that the discrepancies we're going to talk about are very real and have very real impacts on autistic people, on their families, and on people's life expectancy. We also know that autistic people have experiences in eating disorder care that may not be adequately meeting their needs. So the prevalence of autism in patients with an eating disorder, and this comes from kind of a meta-analysis of a lot of different studies, averages to 23% of people in eating disorder care meeting criteria for autism, with the highest rate in an individual study being 30%. So that is a significant portion of people who are seeking eating disorder care. And this is also using the ADOS-2 to identify autism, which as we get further in the presentation, I will learn a little more that the ADOS isn't necessarily a tool that measures the nuances of what autism is. And so I imagine that there may be even higher rates depending on how autism is identified. We also know that people with eating disorders who have autistic traits experience chronic and long-lasting eating disorders. They have poorer outcomes than their neurotypical peers who are also in eating disorder treatment. And so as a field, this is prevalent, and this is really important that we have some basic awareness and understanding of this population. So as I was thinking about like some of the whys in all of this, in the lower life expectancy, the challenges in the healthcare system, in the eating disorder system in general, I think it's really important that we note that autistic people often experience a kind of intertwined experience of different medical conditions that tend to really show up in this population in ways that it doesn't with neurotypical people. And so there's a really wonderful resource called All Brains Belong Vermont, which is an organization put together by an autistic doctor named Mel Hauser. And that organization has done some really awesome work with putting together resources to better understand these intricate different medical conditions and how they intertwine and interconnect and show up for autistic people. So I definitely recommend checking that out if you want to know more about this, because this could probably be a whole presentation on its own. But I think being aware that some common medical conditions that come up for autistic people are hypermobility, connective tissue differences, things like Ehlers-Danlos syndrome, allergies, mast cell activation, dysautonomia, POTS, nervous system problems, irritable bowel, Crohn's disease, general GI symptoms and distress, sleep differences, sleep conditions, chronic pain, autoimmune diseases, and endocrine disorders. And this is absolutely not an exhaustive list. This is a very basic list of common health conditions. And I think it's really important to note that these conditions in and of themselves are probably not the reason why people are dying at younger ages alone. There's likely contributors to that, but these conditions also exist in the context of the world we live in and in the context of accessibility challenges for people who are autistic and need care for their conditions. And so some of those accessibility considerations that we should all be aware of is it kind of goes, there's so many layers to this, so I'm going to do my best to speak to it briefly, but certainly the lack of accessibility to care related to autistic traits that people experience. And so when you think about seeking healthcare, in a brick and mortar setting, there is so much going on in terms of sensory information, in terms of needs to communicate with providers what is happening, coordinating schedules, what you're feeling, what you're experiencing. And that can be challenging for people who communicate differently than the ways that their providers communicate. And then also just navigating the systems. There's a lot of executive functioning that is required to make appointments, to coordinate your providers, to deal with insurance. And that's assuming you have access to insurance, because kind of going back to my uncle's story, he was not someone who could work a 9-to-5 job with the way his brain worked, and he didn't have access to insurance. And that is a really prominent theme in the autistic community. So beyond just the autistic traits, there's also real ableism that exists in our society, and our healthcare system is not immune to that. So research that's been done around kind of the autistic experience in seeking healthcare highlights a few things that autistic people might experience, some of those being providers making assumptions about patients' skills and abilities and needs, and not getting it right necessarily, and creating situations where patients don't feel seen or don't have the accommodations that they need because of that. Holding autistic people to neuronormative standards and expectations. So not being willing to accommodate the ways that we provide care or allow appointments to be set up, or the ways we communicate, because we hold a neuronormative standard and kind of expect people to be able to meet that. And also, I think sometimes providers can kind of fall into the trap of viewing providing an accommodation as like enabling, because we exist in this neuronormative world where the goal oftentimes is to get somebody to be as functional, as highly functioning as they possibly can. And so that can definitely play a role in that. Some other things is autistic people may seek care later in their disease progression because of the reasons just mentioned, right? And so there can be some putting off or avoiding, and maybe those might not even be the right words, right? Because there's lack of accessibility, autistic people may not be able to seek care until it's not an option not to anymore. Autistic people in eating disorder treatment for sure are often more likely to be labeled as treatment resistant when treatment isn't working for them, because it's maybe not working for their brain type, or maybe not working for their needs. And oftentimes standards of what eating should look like are going to be derived from what is, quote, normal, right, for non-autistic people. I also want to briefly mention the double empathy problem. This is a concept that comes from an autistic researcher who is autistic, that really highlights that oftentimes this label of communication or social deficits that autistic people receive really comes from a problem that exists that isn't an autistic person problem. It is just a problem across the board, which is that when you take two autistic people and put them together, they often can communicate with each other and feel that communication and that interaction was fulfilling. When you take two neurotypical people, same result. But when you take a neurotypical person and an autistic person and put them together, that is where the communication breakdown happens. And so the double empathy problem really kind of brings up the question of, is it a deficit or is it a difference? And I think the double empathy problem points towards it being a difference, because it's not necessarily deficit in every situation. And so medical providers and eating disorder providers, we are not immune to being in a double empathy problem without even realizing it. And finally, as we think about the low life expectancy and suicide being one of the leading causes of death for autistic adults, I think it's really important to highlight that existing in a neuronormative society as a neurodivergent person is traumatizing and is distressing. And definitely, I don't know that there is research on that, but I would imagine that likely plays a role in the suicide rates for autistic adults. So I want to take us back in history to just kind of further deepen our understanding of how we got to this place and where some of our biases as providers come from. So we're going to talk a little bit about the pathology paradigm and recognize that so much of the history of autism as a disorder in this pathology paradigm, as an experience and as a neurotype in an affirming paradigm, so much of the historical research is focused on finding and identifying what is the cause of autism and what is the cure for autism. So it has not, for the decades that it's been a term, it has not been researched really from the angle of it just being a difference, so much as being something that we need to get rid of. So the term autism was coined by German psychiatrist Eugene Bleuler, and it was coined to describe a symptom of schizophrenia. And it derives from the word autos, the Greek word autos, which is the self. And it was coined to describe the tendency to be so inward and into the self and kind of disconnected from experiences outside of the self. And so that was kind of where the term began. So it wasn't until later that we really started seeing it being used to describe autism as we think we know it today. And this really, there were kind of these two different people using this term in different places at the same time. So one of the people was Hans Asperger, which some of you may know that Asperger's used to be a diagnosis in the DSM. And Hans Asperger really was a controversial figure in this history because in one regard, he's been kind of painted as somebody who, and I should back up and say Hans Asperger was an Austrian psychiatrist who was doing research on autism. And this was during the time that it was occupied and controlled by Nazi Germany. And so when you look at Hans Asperger, I think there used to be this belief that he was someone who was saving autistic people from the death that would most likely be given to them by Nazi Germany, by highlighting that these, quote, high-functioning people have value to offer. And I think that as time has gone on and more understanding has been established with his role, it's also important to note that he wasn't complicit. He wasn't completely not aligned with what was happening with the eugenics at that time. So just noting that that's part of this history. Then in the US, we have Leo Kanner, who kind of is the first person to publish this really systematic description of what he coins early infantile autism. And his description really founds this basis that has influenced what that has become in the DSM, what the criteria are. And there's a few things with this that I think are really important to highlight. One of which is that his sample, the people that he observed to create this resource were children, and a majority of them were boys, and a majority of them were white, and all of them had wealth and access to privilege. Most of them, the children that he studied, their parents were either professors or doctors, and so this foundation really is kind of based on a pretty small kind of subset of who is autistic. And it's also important to note that in that process, all of the ways of describing this were also deficits based, right? And so it wasn't thinking about communication differences or autistic interests or things like that, so much as it was kind of labeling these things as how far they deviated from what's normal, quotes, and how different these kids were from neurotypical people. So autism first appears in the DSM-3 and has had its share of revisions and changes, just like all diagnoses in the DSM. But I think it's just really important to note that autism is something that the understanding of autism and what it is, even within the pathology paradigm, has shifted and changed and made room for more nuance in some ways over time. And so I think it's just really important to remember that like what we think we know right now about things is always likely going to change as we learn more and expand our knowledge. And also noting that historically, autism has always been classified and approached as a deficit and measured, like I said, as a deviation from what's normal. So here is my little pathology paradigm 101. We have our doctor explaining to our autistic child here, you don't think like me, act like me, or experience the world like me. Your experience is a disorder. So beyond just this pathology paradigm that we exist in, there has also been very real marginalization and harm that has been done to autistic people. And I'm going to highlight like a very brief snippet of this. If this is something that is interesting to some of you, if this piques your interest, I highly recommend there's an autistic advocate named Kieran Rose who does a really, really great course called The Insight of Autism, and it's goes very in depth with a lot of these things. But for the purpose of time, and let me get back to the slide. We're going to go through just a few. So we already talked about Hans Asperger, and I think it's really important to note that autism in this context of Nazi Germany is something that existed in a culture where that was considered undesirable. It was not a desirable human quality to have. And the goal of eugenics is to eradicate that. Then as we go kind of more into the not so distant past, we also, I think it's important to talk about Ole Ivar Lovaas, who is somebody who had a very, very strong influence on the development of ABA therapy. And if anybody knows anything about autism, probably something that comes straight to mind is ABA therapy, because it is often recommended as the gold standard of care. And Lovaas has a very strong basis in behaviorism. And I want to highlight that Lovaas also was involved in a project called the Feminine Boy Project, which essentially was what we know as conversion therapy for gender nonconforming individuals. And the methods used in this Feminine Boy Project are pretty much the same methods that were used in ABA therapy. ABA therapy's changed to some degree over time, but pretty unanimously, the autistic community is against ABA therapy because for autistic people, ABA therapy is very similar to conversion therapy in that it is trying to get somebody's brain and neurotype to look like something that it is not and to be something that it is not. We also have organizations like Autism Speaks, which most of you probably have heard of, because when anything autism, Autism Awareness Week, Autism Acceptance Week, Autism Speaks is right there. One of the biggest, most well-known organizations in this kind of realm. And Autism Speaks, their logo is a puzzle piece, which autistic people find generally pretty offensive because it essentially implies that autistic people are broken, that autistic people are not complete, and that they are missing a piece of a puzzle. And there's just something not right about them. And Autism Speaks really does operate from this idea that autism is a disease that needs to be cured. In 2009, they released a commercial that's called I Am Autism, and you can look it up on YouTube if you feel so inclined, that essentially the tone, the words, the whole thing is really to scare people into this idea that autism is going to come into their life, take over their child, and completely ruin everything for their kid, for their family, for their life. And it is very much a message that autism is not only bad, but also scary and also life ruining. Autism Speaks does not include autistic people in their leadership, in their boards. And for an organization called Autism Speaks, they also pretty actively silence autistic voices, which is a little ironic. So there's a whole lot, and like I said, this is a very just kind of general outline of some of the harms and some of the marginalization that exists for autistic people. And so I think as we are working on this idea of deconstructing our biases and really going inward to question what are we influenced by as providers, I think it's really important to question these kind of gold standards that we have set in the field by recognizing that they are based on research that is done from this pathology paradigm, that has not included autistic voices, that has not been done by autistic researchers. And oftentimes what it is actually measuring is a goal or a trait that has been deemed or decided by like a neurotypical person or neuronormative society, really. And so when we think about things like ABA, what does ABA do? It measures how closely can this person look neurotypical? How closely can we get them to conform to our neuronormative standards? When we look at the assessments to identify autism, oftentimes those assessments are also kind of looking at how stereotypically does this person look like what is outlined in the DSM criteria, which I think we kind of talked about that's not probably a very nuanced look at all autistic people. And overall, I think a lot of times the field looks at how can we take this broken person and move them towards being more normal. I have a quote from an autistic person, Jim Sinclair, that was from the Autism Network International newsletter in 1993. Autism is a way of being. It is not possible to separate the person from the autism. Therefore, when parents say, I wish my child did not have autism, what they're really saying is, I wish the autistic child I have did not exist, and I had a different non-autistic child instead. Read that again. This is what we hear when you mourn over our existence. This is what we hear when you pray for a cure. This is what we know when you tell us of your fondest hopes and dreams for us, that your greatest wish is that one day we will cease to be, and strangers you can love will move in behind our faces. So from an autistic person, I think that quote is pretty powerful about what it feels like to exist in the pathology paradigm when you're the one being labeled as wrong. So shifting into what does it look like to develop new perspective on this, right? If we question and look at and think about the pathology paradigm, what does it look like to not be in that? Overall, I think that autistic people, autistic providers, autistic researchers are really trying to focus on a strength-based and affirming perspective of autism as a neurotype. Many of the current diagnostic criteria really describe like observable outward behaviors. And oftentimes those observable outward behaviors are actually things that autistic people do when they are in distress, which is pretty limiting and doesn't really account for different things like autistic people engaging in masking, autistic people existing when they are not in distress, autistic people who hold intersectional identities and that influence the way their autistic traits present, people's internal experiences of their brain and of their thinking and of their way of perceiving and interacting with the world. And it also doesn't leave too much room for autistic traits to exist in a way that is not labeled as a deficit. So I really like this. Matt Lowry, his information's down here, is an autistic person who is also an autism evaluator, a psychologist. He's in Kentucky, and he rewrote the DSM criteria from a strengths-based perspective. And I think it's a pretty interesting take on what it would look like to think about these traits in a way that wasn't just like inherently pathologizing them. So we'll go through them quickly. So criteria A, we have different social communication and interaction rather than deficiencies there, as evidenced by the following: differences in communication, tendencies to go off on tangents, tendency to talk passionately about special interests, and tendency to not engage in small talk. Differences in nonverbal communication, including stimming while talking, looking at something else while talking, and being bored in conversations. And then number 3, due to the above differences in communication, autistic people tend to be shunned by neurotypicals and therefore are conditioned to believe we're somehow less social. Matt is a little sarcastic, and I appreciate that. Criteria B, repetitive behaviors or interests is evidenced by at least 2 of the following: stimming or engaging in echolalia, security and routines. Autistic people do not have a sensory filter, so the world is perceived as a constant state of chaos. Routines and expectations give comfort to overwhelmed autistic people. Special interests. Due to hyperconnected brains, autistic people feel more passionately about what we love. So when we have a special interest, we tend to fawn over and fixate on it. And that takes me back to my picture of the Spirit of St. Louis and thinking about how experts come often from these special interests. Number 4, hyper or hyporeactivity to stimuli. Again, due to hyperconnectedness, we feel things more intensely. Sometimes, however, we feel things less intensely because we tune them out in favor of other stimuli. Letter C, we're born with these traits, but learn how to mask them. Sometimes they only show up when we're stressed and let our guards down. And letter D, these traits cause other people distress. Note, the DSM only indicates impairment when it affects other people or jobs, but not when it's a daily issue that we learn to live with. And E, this is not due to an intellectual disability. So I highly recommend Matt Lowry. He's got some just really, really awesome stuff in terms of understanding some of the more nuanced ways of viewing autism. So in the criteria, he also mentioned masking, which I think is important to talk about in this context. So masking is hiding autistic traits, hiding differences, and attempting to appear more neurotypical on the outside. So somebody perceiving an autistic person who is masking will only see that interaction from what it looks like on the outside and may miss the things that happen internally, like scripting an entire conversation, planning and rehearsing and practicing and feeling anxious and going over it and over and over it in your head. People don't see that from the outside, what's actually happening internally when somebody is masking. Masking it's not always something that somebody is consciously doing. It is self-protective. And that's because it is an attempt to protect from the very real neuronormativity that autistic people experience, the social judgments, the pressures to conform. And high masking individuals are unlikely to be identified as autistic if they are interacting with providers who only know about the stereotypical kind of outward symptoms of autism, as we've kind of gone through in this presentation. And we know that masking is really quite detrimental to mental health because it takes a whole lot of cognitive and emotional energy to hold up this mask. It contributes to burnout. It contributes to like identity problems where we're like, who am I? Who am I actually if I'm not masking? And it contributes to shame. So this is a quote from Devin Price. It comes from the book Unmasking Autism, which is a really great read if this is interesting to any of you. Though masking is incredibly taxing and causes us a lot of existential turmoil, it's rewarded and facilitated by neurotypical people. Masking makes autistic people easier to deal with. It renders us compliant and quiet. It also traps us. Once you've proven yourself capable of suffering in silence, neurotypical people tend to expect you'll be able to do it forever, no matter the cost. Being a well-behaved autistic person puts us in a real double bind and forces many of us to keep masking for far longer and far more pervasively than we want to. So just something to be aware of as you are working with autistic people and the ways they may show up. I want to also note the idea of intersectionality in identities. So autistic people view autism as an identity. It is an identity for them. And it is an identity in the same way that other marginalized identities exist and intersect together. So for women and for people who are assigned female at birth, they're less likely to be diagnosed accurately. And this is even when they display pretty stereotypical behaviors that are kind of looked at for these criteria, because oftentimes they're more likely to be diagnosed with borderline personality disorder, anxiety, PTSD. I think on average, women and people who were assigned female at birth go through, I want to say, 6 misdiagnoses before they actually get to an autism diagnosis. So it's pretty pervasive. BIPOC autistic people are more likely to be misdiagnosed with behavioral and oppositional disorders, which I think speaks to other systemic biases and racism and ways that our systems operate from those places. The autistic community in general also has high rates of trans and gender nonconforming individuals who face marginalization with those identities. And people who are in poverty are less likely to have access to getting a diagnosis or access to the care that we've talked about. So another quote from Devin Price, also from Unmasking Autism. Autistic women, transgender people, and people of color often had their autistic traits ignored when they were young or have symptoms of distress interpreted as manipulative or aggressive. So did autistic people who grew up in poverty without access to mental health resources. Gay and gender nonconforming men often didn't fit the masculine image of autism well enough to be diagnosed. Older autistics never had the opportunity to be assessed because the knowledge about the disability was so limited during their childhoods. These systemic exclusions have forced an entire massive, diverse population of disabled people to live in obscurity. So, as providers, what does it look like to shift from ignorance, from not knowing, from really being informed by systems that exist in all this history that we talked about, into being in allyship with autistic people? Here are a few important mindset shifts to think about and to really start to try to incorporate if allyship is something that you are interested in incorporating into your practice. These come from an article that was published in Frontiers in Psychiatry, actually in August this year, so pretty recently, from the University of Washington. The name of the article is Mind Shift in Autism, a call to professionals in research, clinical, and educational settings. Hi, Ashley. Okay, so we'll go through these, and just kind of consider like what would this look like in practice for you, for a professional, in whatever capacity you work with autistic people. So here are the mindset shifts. Autism is an illness to cure versus treatment should help autistic people live a high quality of life. Measuring success by how normal somebody acts and appears versus measuring well-being outcomes. What are we measuring when we're working with our autistic folks? Having treatment goals that are dictated by providers and kind of identified as what is normal, what is good, what should you be doing, versus treatment goals that honor autonomy and work really collaboratively with our autistic clients. Holding a belief that clients should conform to treatment, should make themselves work in the treatment that they have, versus the belief that accessible care through accommodations and supports are a human right. Holding an inflexible one-size-fits-all when it comes to the rules and expectations when we are engaging in treatment, versus really focusing on individualized and collaborative care and treatment for autistic people. Viewing a deficits-based conceptualization of autism in the scope of what we are doing versus trusting and empowering autistic people to know their experiences and helping them identify and express their needs. And viewing autism as a pathology versus viewing autism as a marginalized identity through a social justice lens. So as we wrap up, this is our last slide with content on it. I wanted to just kind of leave with some reflections to consider. I'm hoping that the information from this presentation plants some seeds, and I'm hoping that it does prompt some reflection and just kind of some internal thought and growth. So power is the ability to influence and make decisions that impact others. Autistic people historically have not had power over the systems that we exist in. And I want to go back to the statistics we talked about when it comes to eating disorder care. For individuals with eating disorders who do have autistic traits, this overlap is associated with chronic and long-lasting eating disorders, as well as poorer outcomes than neurotypical people with eating disorders. So here are some things I think it's important for us as a field and providers in this field to ask ourselves, especially considering that we're looking at somewhere between 20 to 30% of the people we're working with likely having autistic traits. So, to what degree are outcomes for autistic people in eating disorder care related to a lack of autistic representation in the creation and implementation of the treatment we provide? How can learning from autistic voices and lived experience in the eating disorder field change the ways that we meet autistic needs in treatment? And how can we as a field give power to autistic people and invite them into the conversation, into the solutions, into the process? So with that, I think we've covered the content.
Wonderful. Thank you, Brittany. And I can share for everyone here, that was such an insightful presentation. I know I appreciated everything, and I'm sure everybody in the audience did as well. We did have one question that did come about. As a therapist, how would you recommend approaching a masking patient, and what recommendations do you have to help relieve the patient from masking during therapy?
Yeah, I love that question. I think that this is where it's really important when working with autistic people to have knowledge about what autistic experiences can look like, because sometimes people aren't even aware they're masking, and they're finding themselves really burnt out and really unable to kind of identify what is authentically who they are versus what are they showing people. So when it comes to working with a high masking client, I think it's really important to start with helping that individual to really kind of contemplate and reflect and get curious about what am I doing that is masking, while also holding the space that is self-protective, right? Like, we don't want to shame that. And what would I be doing if I weren't masking, right? And so a lot of times that can be things like helping the client to identify who is benefiting when they're masking. What are the factors in the environment or in the interaction or in the world we live in that are contributing to the need to mask, while also helping them reflect on, when do you feel your most authentic self? When do you feel the most content? When do you feel the most alive? and kind of exploring that not only in the moment but also across the lifespan, and kind of looking at like helping do some values work. A lot of times autistic people are quite values driven, and really being able to kind of tap into values and tap into those times that somebody feels really fully themselves, and help them expand on that, right? Help them think about, what does it look like to show up authentically myself? When is it safe to show up in an unmasked way? I think that as a therapist, also like creating the space for unmasking in therapy is something that takes time and trust, and it takes the ability to show somebody that you are not going to pathologize and judge and shame their unmasked selves. And so doing the work internally is a big part of that too. Hopefully that helped answer the question.
No, that was wonderful, Brittany. Thank you. Thank you again.
Thank you.
As we sign off, I just want to set a reminder. I have my email and the CEGO information in the chat as well. So feel free, if there are any additional questions, you may reach out via that way. Or if you need any support receiving your certificate, the CEGO information is there as well. Also want to say we have another great day tomorrow filled with summit activities. Please feel free to check those out. We have some wonderful presenters just like Brittany joining us. So make sure to check those out. And thank you all for sharing the space. And thank you, Brittany, for such a great presentation today.
Thank you.
Have a
Bye,
wonderful day,
everybody.
everyone.